I think that we have to keep on.
Next speech is about small vessel disease in the brain, and is given by Professor Leonardo Pantoni from the University of Florence. Thank you for coming.
Good afternoon, or if you prefer, good evening. Thank you very much, Professor Fabbri, for the invitation to be here and the honor to be one of the two neurologists in the room, I guess. I'm also very happy to be here. I'm learning a lot about small vessel disease in parts of the body, which are not the brain, which is my main topic. So, what I will try to do during these lectures to try to give you an overview of what we mean by cerebral small vessel disease and what is the current view on this topic. This is one of the reviews that have been published on the topic. This is a review of mine, and you might want to refer to it, and you will see many of the things I'm going to deal with this afternoon already in this paper. And if you prefer, there is also a book on the topic, and this is basically my only disclosure for today, even though the financial disclosure are very, very little in this sense. Now, cerebral small vessel disease of the brain. Some people think this is the most common neurological disease, as you can see here highlighted in yellow, because it's very, very prevalent, as I will try to show you during this lecture. The second thing I want to make clear is that probably this is a systemic disease. So we are talking about a small vessel disease in different parts of the body, but probably this is at least to some extent a systemic disease. So we need to be more in touch to each other to talk about microvessels. What is the prevalence of the disease? If you consider ischemic stroke, about 1/5 of ischemic stroke in Western countries are due to small vessel. But if you go somewhere else in the world, for example, if you go to Japan, about half of the ischemic strokes are due to small vessel disease. And the problem is even much, much more important if you consider forms of small vessel disease which are not obviously linked with stroke. These are data about silent strokes, silent lacunar infarcts in the brain, infarcts that have not produced a clinical obvious stroke. The prevalence, as you see, is increasing with age, and as you can see here, is very, very high. If you go up to 80 years old of age, you see that, for example, 40% of subjects in the population have some kind of small vessel disease in the brain. So it's a very prevalent disease. And these infarcts are silent because they do not produce stroke, but they give a lot of problems, as I will show you later on. What kind of vessels are we dealing with when we consider small vessel disease in the brain? We are dealing with vessels that are 1-2 millimeters in diameters and go down to a few hundreds or even less microns. So these are very tiny small vessels in the brain which are located in the deeper structures of the brain. And of course there are different forms of this small vessel disease. Professor Crea showed you a sort of a classification of microvessel disease for the heart, and I'm doing kind of the same thing for the brain. This is a proposal for classification of small vessel disease in the brain. Type 1 is arterial sclerosis, so it's age-related or vascular risk factors related small vessel disease with different subtypes. Then we have another important form, which is cerebral amyloid angiopathy in the brain that can be sporadic or genetic. And then we have a third group, which are the inherited and genetic small vessel diseases. An increasing group, there are more and more diseases that are recognized to be genetic in origin and gives small vessel disease in the brain. Then type 4 is inflammatory and immunologically mediated small vessel disease, and you have all kinds of vasculitis, systemic vasculitis or just primary vasculitis of the central nervous system. And then you have more rare forms of small vessel disease in the brain, like venous collagenosis and other small vessel disease, for example, post-radiation small vessel disease of the brain. We can take a look at the pathological phenotype of these conditions. Here you see the typical changes in the small vessel of the brain when you have arteriolosclerosis. You have loss of muscle cells in the vessel. You have lumen restriction. You have deposits of hyaline material in the wall of the vessel, and you have typical ischemic changes that you can see under the microscope. You see here ischemic changes of the white matter. You see here a typical lacunary infarct. On the other side, you have hemorrhagic forms of small vessel disease in the brain, typical again changes in the small vessel with the so-called pseudo-aneurysm and the typical hemorrhagic manifestation of the disease. This is from the pathological point of view. Or you can have a clinical approach to the topic. These are the clinical consequences, some of the clinical consequences of cerebral small vessel disease in the brain, that I like to divide into two main types. The first is acute, and of course acute means stroke, lacunar stroke, ischemic or hemorrhagic stroke on the other side. And then you have a very important, very prevalent chronic consequences of cerebral small vessel disease in the brain, because this is related to dementia and cognitive impairment, is related to what we see as old age depression and depressive symptoms, what we see in terms of gait disturbances in the elderly, and also patients with sphincteric disturbances due to small vessel disease in the brain. There is, of course, a progression of these changes and a progression of the clinical consequences. For example, if you take as an example cognitive performances, you can have very mild deficits in the beginning that you can pick up only, for example, during neuropsychological tests. Then you have an intermediate stage when you have some cognitive problems, but the patient is still able to do his or her normal life. And then you have the more severe forms of cognitive impairment, you have dementia. And there is a progression from one stage to the other when you are dealing with these chronic consequences of cerebral small vessel disease. Now, besides the pathological and the clinical aspects of the topic, what today we are concentrating on and what today we have in mind where we are talking about small vessel disease in the brain and cerebral small vessel disease in general is this kind of definition. First of all, it's quite obvious that small vessel disease is a term referring to different pathological processes and mechanisms in the brain that all have in common the presence of some sort of damage of the small vessels, either small arteries or arterioles. The results of this small vessel disease are lesions located, of course, in the brain, particularly in the subcortical and deeper structure, lacunary infarcts, white matter lesions, major hemorrhages, and microbleeds. I will come back later on the topic of microbleeds. The most important concept, perhaps, of this presentation today is that because these lesions can easily, the parenchymal lesions, be detected by neuroimaging, the term small vessel disease is today frequently used to describe the parenchymal lesion rather than the small vessel disease itself. So that's a very important concept to keep in mind, at least when we are talking about small vessel disease in the brain. So we are very far from dealing with a picture like the one on the screen. So we are not able, at least today, to visualize small vessel in the brain like in this picture over here. And what we are talking about when we are talking about small vessel disease in the brain is this kind of picture. So neuroimaging correlates of small vessel disease. And here you have the hemorrhagic forms. You see here this small hypo-intense dot in the brain, which are micro hemorrhages, large hemorrhages, of course. And here you have the ischemic consequences, white matter lesions, also called leukoariosis, and lacunar infarcts as well. And how can we assess and define this changing? We have visual rating scales, for example. This is just an example, a rating scale for white matter lesion that we developed a few years ago. Another example, talking about microbleeds, we have scales like this one to measure, assess, and detect these kind of lesions in the brain. In terms of pathophysiology, of course, we always start with small vessel disease in the brain, and there is a partial influence of risk factors, I will be back to that, and a partial influence of genetic factors. Then we have basically two ways. On one way, we go to the ischemic consequences. On the other way, we go to the hemorrhagic consequences. Here you have basically a reduced cerebral blood flow with a chronic diffuse ischemia or a more acute, severe, and localized ischemia, leading to white matter lesions or lacunar infarcts. On the other side, you have major or minor hemorrhages in the brain. And there is a long-standing process that affects the patients for many years. Now, which are the risk factors for cerebral small vessel disease? Here you see risk factors for lacunes and risk factors for incident lacunes, so for new lacunes to occur in patients. Data from two large population-based studies. The cardiovascular health study, lacunes were related to aging, to blood pressure, creatinine, smoking, male sex, diabetes. Similarly, in the ARIC study, diabetes, again, measure of glucose intolerance, cholesterol, hypertension, smoking. When you go to incidence lacune, again, the Rotterdam study, aging, female sex this time, and some measure of carotid atherosclerosis. Our latest study showed again that a predictor of incident lacunes was the baseline severity of cerebral small vessel disease, again, systolic blood pressure. There was a strange and unexpected association with high diastolic blood pressure and high LDL cholesterol, but as protective factors in terms of incident lacunes. Very similarly for white matter hyperintensities, risk factors are hypertension, impaired cerebral vasomotor reactivity, postural hypo or hypertension, fluctuation of blood pressure, variability of blood pressure, smoking, high homocysteine level, low vitamin B12 and folate levels. Most community-based cross-sectional studies have failed to find an association with diabetes, and the association between cholesterol levels or statin use and white matter hyperintensity was less consistent and sometimes was even contradictory. Again, for progression, we have baseline load, lesion load, age, smoking, hypertension. So you see that there is some consistency in all these studies, for example, about hypertension, some inconsistency for other risk factors, for example, diabetes. And what about microbleeds? Again, hypertension, diabetes, smoking, age, total cholesterol level, but this time it was a low level of cholesterol to be a risk factor for these microhemorrhages. Statin use, risk factor for microhemorrhages. Proteinuria, homocystinemia, female sex, some genetic factors. Very similar situation for incident microbleeds. Since we are in a conference about pulmonary disease, I went back and found this this study of ours. That was a study on the association between respiratory function and white matter changes. This was a collaborative study done with the women population-based study in Gothenburg. We had the chance at that time to review all the neuroimaging, and we were able to show that white matter lesion and lacunar infarcts in these elderly women were related to lower midlife respiratory function. These are the data showing that here you have evaluation of respiratory function with all these variables you are familiar with, and then we have a final evaluation 20 to 25 years later with neuroimaging, and we found this kind of association that I think is particularly of interest for this kind of audience. Same study and a little note about blood pressure. It is important to keep in mind that this is a long-standing process, so we have to measure things and risk factors for years. And again, in Gothenburg, we were able to show that there is a relation between midlife hypertension, particularly in this case diastolic blood pressure level, and the presence of white matter changes and lacunar infarcts as well. So in overall, it seems that cerebral small vessel disease is another aspect of a systemic disease, and we should consider cerebral small vessel disease as part of the target organ damage in patients with hypertension, which is not in many instances the case. And just to give you another addendum to this concept, for example, the relation between cerebral small vessel disease and renal function. There are data about this. For example, this is just one of the latest study just published on the association between the low estimated glomerular filtration rate and the risk of cerebral small vessel disease. This is a meta-analysis, and it's clearly that there is an association, either if you are talking about silent cerebral infarction, white matter lesion, microbleeds, lacunar infarction, there is an association with these renal variables and cerebral small vessel disease. Now, going back to what today we consider and we define cerebral small vessel disease, we have to keep in mind that for years we have been able to see cerebral small vessel disease, but we were able to see these changes only from the pathological point of view. This is the typical classical and seminal work by Miller-Fisher, a typical clinical pathological study. But the big revolution in this field came when neuroimaging was introduced in the 80s of last century with the introduction of CT scan and MRI. Of course, you see here this high point density areas in the brain and these hyper-intense areas in the brain, which are termed today leukoariosis, a term that was introduced to be very general, not meaning that much at that time, but now today we know that these changes are indeed relevant from the clinical point of view because they are related to the onset of dementia in our patients, and overall they are related to disability. You see here in our European study that if you have severe white matter changes in the brain, the risk of becoming disabled after 3 years is much higher than if you have moderate or just minimal changes in the brain. So it's an important predictor of disability in our elderly patients. But then the neuroimaging techniques have advanced a lot, as you know, and in the 90s were introduced the gradient echo T2 star-weighted sequences able to detect microbleeds in the brain, and it was at that time clear that these small areas were indeed small micro-hemorrhages in the brain. And today we know that these microbleeds are related to a particularly risk of hemorrhage in some therapeutic condition like the use of antiplatelet, anticoagulation, and thrombolysis, and they are associated with cognitive deficits and are a disease marker of some peculiar small vessel disease in the brain like cerebral amyloid angiopathy. So they are very important. Their prevalence is high, about 10% in the general population, but in some stroke population they go up to 40–50% of patients having this kind of microhemorrhages in the brain. So it's obviously a very prevalent disease. Neuroimaging is advancing every day, and now we are able to see things that we used to be able to see only under the microscope, like this cortical, very tiny microinfarcts. Today we see the same picture here in a 7 Tesla machine in the brain, in vivo of course, so you can detect microinfarcts in the brain. So it's evolving a lot, and this is the reason why we need new standards for this. We set an international group to work on this standardization of neuroimaging correlates to small vessel disease. I give you a very brief overview because the time is strict, of course. And why do we need standards for imaging small vessel disease in the brain? First of all, because, as I said, this is an important topic from the clinical point of view, from the epidemiological point of view, and also because there are now trials targeting specifically this disease. This is the SPS3 trial that has been published in New England a few years ago. These are trials targeting specifically small vessel disease in the brain. So we need to be harmonized from this point of view. And instead, the terminology is very variable, or at least has been variable in the past. And there is no consensus on the definition of some lesions. For example, lesion like this, how would you call? When you see the follow-up scan, you see a lacunes here instead of the acute lesion. You may want to call this a lacunar infarct, but if the follow-up is like this, it's the same kind of picture, the lesion does not cavitate, and you may have difficulty in finding and in calling this a lacunar infarct. So we need standards for this, and what we have done, we have tried to develop definitions, and you may refer to the paper if you want to read more on this. These are all the kind of lesions that we may call as cerebral small vessel disease today in the brain. We have also developed some kind of, I hope, useful information in terms of panels like this, like drawings that can help physicians and doctors and researchers to harmonize the nomenclature on this topic. Now, to summarize what I have tried to overview with you today about small vessel disease in the brain, the disease is common, I would say very common. It is clinically relevant, I would say very relevant. At least partly it's a systemic disease. This is not true for all kinds of cerebral small vessel disease. For example, cerebral amyloid angiopathy is specifically a brain disease, but in most instances this is a systemic disease indeed. Today, at least for us neurologists, it's important to refer to this problem in terms of neuroimaging definition. It's our basic language. And of course, about prevention and treatment, we have a lot to do, a long way to go. Thank you very much.
May I ask? Oh no, because there's a question like that.
Thank you. Marco Bertolotti. Very nice presentation, a very stimulating one also. I'd like you to comment a little bit more on the possible relationship between serum cholesterol and small vessel disease, because what you've showed us is kind of puzzling, and you showed us that sometimes low plasma cholesterol can be detrimental to the human brain, probably. And this is not very different from what we see in the literature sometimes related to neurodegenerative disease, Alzheimer's disease. So I'm asking you, do you think this might depend on particular subsets of patients, to the age of patients, and what is your view on the relationship between cholesterol and small vessel disease? Thank you.
Thank you. Well, indeed, the relation between cholesterol and microvessel disease in the brain is a peculiar one. For some risk factors, for example, aging, if you consider aging, of course, a risk factors and hypertension, it's quite obvious that these are risk factors for both small and large vessel concerning the cerebral circulation. Cholesterol is instead, high cholesterol level is instead a clear risk factors only for large vessel disease in the brain. So that's the first point. It's very rarely found as a risk factor for microvessel in general. Then there is this peculiar aspect that for some sort of microvessel, like microhemorrhages, can be even not a risk factor, the high level of cholesterol, but the low level of cholesterol, and maybe statin use. This is quite in line with all data from for major hemorrhages. As you might know, low level of cholesterol were related in the past to the presence of major hemorrhages in the brain. It's not clear why some people thought there was an interrelation with alcohol consumption. It's not very clear. So I cannot give you an explanation about this. In terms of statin use, for example, data from the Sparkle study showed that patients who were included in the trial for a stroke, for an hemorrhagic stroke, had an increased risk of hemorrhagic events when they were put on statins. So it seems that statins are not good for microvessels in terms of microhemorrhages, and I cannot tell you anything more than this. I know that statins have been proposed to be used for Alzheimer's disease, but still it's not clear. Okay. Thank you.
Many thanks. Thank you. Excellent talk.